Okay, let's unpack this. Have you ever stopped to truly marvel at how something as um, intricate and vital as your arm or leg,
Yeah.
with its precise arrangement of bones, the coordinated power of its muscles, and the delicate network of its nerves, evolves from just a handful of cells into a fully formed, functional structure?
It's pretty amazing when you think about it.
Today, we're embarking on an incredible journey, a deep dive into the amazing process of limb development.
What's truly fascinating here is that we're going to trace this journey from the very earliest stages,
Right.
understanding not just what happens in this remarkable transformation, but critically, why each step matters. Especially for you as a future clinician, grasping these foundational processes is essential.
Definitely.
Our mission for this deep dive is to give you a clear, memorable roadmap of prenatal limb development, show you how common abnormalities can arise, and help you define key terms like dermatome and myotome, both developmentally and, in their crucial clinical context.
Think of this as your personal shortcut, your backstage pass, to understanding the musculoskeletal system's grand opening, the development of our limbs.
Exactly.
We're here to distill the need-to-know nuggets, spiced with engaging analogies and mnemonic anchors, ensuring these complex concepts stick with you, not just for your first year of medical studies, but throughout your entire career.
That's the goal.
So before we can even begin to imagine those tiny limb buds sprouting, we need to set the earliest stage, gastrulation.
Right.
For those of us who might need a quick refresher, how does that initial architect's blueprint phase, where our bilaminar embryonic disc transforms, specifically set the stage for something as complex as a limb?
That's a perfect place to start. Remember, gastrulation is where our embryonic disc essentially reorganizes, creating the three fundamental germ layers: the ectoderm, endoderm, and, most crucially for our discussion today, the mesoderm.
Ah, the mesoderm.
This process is truly the beginning of morphogenesis, the development of the body's form. The key insight here is that while all three layers are vital for different systems, it's the mesoderm that's the absolute star player for our limbs.
So it's all about the mesoderm then, that really streamlines our focus.
Exactly. The primitive streak acts as a migration highway for epiblast cells, guiding them to differentiate into their specific mesodermal fates.
Okay.
We're particularly interested in two types here: the lateral plate mesoderm, which gives rise to components of the limbs, body wall, heart, and serous membranes, and the paraxial mesoderm.
And the paraxial mesoderm is where things get really interesting, isn't it? Because that's where we start to see the segmented building blocks of the body appear.
Indeed. The paraxial mesoderm begins organizing into segmented structures called somatomes in the third week. Then these compact into distinct somites on each side of the neural tube.
The somites, okay.
These somites form in a remarkably orderly craniocaudal sequence, about 3 pairs a day, accumulating to around 42, 44 pairs by the end of week 5.
Wow, 3 pairs a day.
You can think of them as the embryo's initial, temporary, but absolutely essential building blocks, like modular units being laid down in precise order.
It's astounding that these transient structures are so critical. How do they know what to become? I mean, if all somites look alike at first, what determines whether one will contribute to a rib, a vertebra, or, say, a muscle for your arm? That's a fundamental question.
That's a truly profound level of early organization, and it gets right to the heart of how our body plan is established. As these somites mature, they don't just stay uniform, they differentiate into very specific regions, almost like specialized departments in a construction company.
Okay.
Each somite divides into 3 key compartments. First, the sclerotome. This is the ventromedial region. For recall, remember S for sclerotome, S for skeletus.
I got it.
Cells from the sclerotome will migrate and differentiate into chondrocytes, contributing to the vertebrae, ribs, skull bones, middle ear ossicles, and the entire vertebral column. It's the bony framework crew. Then we have the dermatome. This is a double-layered structure that gives us 2 more critical components.
Okay.
The dermatome, the outer region which gives rise to the dermis of the back skin. Think D for dermatome, D for dome.
D for dermis. Easy.
Then the myotome, the lower layer containing myoblasts, are muscle-forming cells that will form both axial, back muscles, and appendicular, the limb skeletal muscles. Think M for myotome, M for muscle.
M for muscle. Okay, so a temporary structure like the somite isn't just a fleeting building block. It's a master architect laying down permanent foundational lines for our entire body plan. That's a truly profound level of early organization.
Exactly.
And to implicitly answer my earlier question about how a sea knows its fate, It depends on its position,
Oh,
right?
Leslie.
A somite in the thoracic region will form ribs, while one closer to the neck might contribute to an arm muscle. It's all about context, even at this early stage.
Precisely. Somites are temporary, but they are absolutely essential. They define the segmental body plan of vertebrates and provide a crucial template for spinal nerves to follow as they grow out.
Oh, okay.
It's a fantastic example of transient structures establishing permanent organizational patterns.
With that fundamental blueprint laid, the real adventure begins in week 4. It's like the embryo suddenly decides, okay, time to sprout some limbs.
Yeah, basically.
What exactly kicks off this incredible visible journey of limb bud formation, which then continues until week 8, with the lower limbs always lagging just a bit behind the upper ones?
Limb development starts with the activation of mesenchymal cells, specifically from the somatic or parietal layer of the lateral plate mesoderm.
Okay, the lateral plate mesoderm again.
Yes, these activated cells form what we call the limb buds. The upper limb buds are the first to appear around day 24, emerging as small bulges at the caudal, cervical, and upper thoracic segments, roughly C5 to T1.
C5 to T1, okay.
The lower limb buds follow shortly after, by the end of week 4, developing at the lumbar and upper sacral segments, from L1 to S1.
These early limb buds are fascinating because they're not just one uniform mass of cells. They're a true team effort, aren't they? Bringing together different cellular contributions. Where do all these different cells come from to form a limb bud?
It's indeed a multi-source effort, which highlights the incredible coordination in early development. The mesenchymal core of the limb bud comes from several places. The lateral plate mesoderm, this is the primary source, forming the skeleton, connective tissue, and some blood vessels within the limb.
Okay.
Then somites. Mesenchymal cells from the myotome portion of nearby somites migrate into the limb bud. These will become the precursors for the limb's muscles and some endothelial cells.
Right, the M for muscle part.
Exactly. And finally, the neural crust. These remarkable cells also migrate into the limb, where they differentiate to form Schwann cells of the peripheral nerves, the sensory nerves themselves, and even pigment cells like melanocytes in the skin.
That's a busy neighborhood for such a tiny structure. So you have this core of mesenchymal cells from different origins all working together. But how does this limb bud then know how to grow outward in the right direction and create a perfectly proportioned arm or leg? There must be a master controller, right?
Absolutely. Overlying this mesenchymal core is a layer of cuboidal ectoderm, but at the distal border of the bud, it thickens to form a critical structure, the apical ectodermal ridge, or AER.
The AER. Okay.
What's fascinating here is that the AER acts as the conductor of limb growth. It's a multi-layered epithelial structure that is absolutely essential for limb outgrowth.
The conductor. I like that analogy.
It orchestrates development in a proximo-distal direction, meaning from the base of the limb, like the shoulder or hip, all the way to the tip, like the fingers or toes. If the AER isn't functioning properly, limb development can halt prematurely, leading to a shortened limb.
So the AER is not just a leader, it's constantly telling the cells beneath it what to do.
That's right.
It induces the adjacent mesenchyme to remain as a rapidly proliferating, undifferentiated population of cells. This is what we call the progress zone. These cells are like the energetic construction crew, constantly adding new material to the growing limb. As cells move further away from the AER, they lose this inductive signal and begin to differentiate into cartilage and muscle, working their way from the shoulder or hip down to the fingers or toes.
It's a beautifully orchestrated dance of growth and differentiation. Really quite elegant.
So by week 6, those limb buds have flattened out into distinct hand plates and foot plates. But how do we get individual fingers and toes from what still looks like a solid paddle? Here's where the cellular sculptor comes in.
Indeed. It's a fascinating process of refinement. By the end of week 6, the mesenchymal tissue in the hand plates begins to condense, forming distinct finger buds, also known as digital rays.
Digital rays. Okay.
Toe buds follow a week later, in week 7. The AER, at the tip of each digital ray, induces the formation of the mesenchymal primordia for the phalanges. Then, crucially, apoptosis-programmed cell death occurs in the intervening mesenchyme.
Apoptosis.
This forms the notches between the digital rays, ultimately separating the digit by the end of week 8.
It's incredible that such a destructive process is so vital for construction. But why apoptosis specifically? Couldn't the cells just stop dividing or move out of the way? What makes programmed cell death the most efficient mechanism here?
That's an excellent question. Apoptosis is incredibly precise and, well, clean.
Clean.
Instead of just migrating or ceasing division, which might leave residual tissue or kind of messy boundaries, programmed cell death ensures a neat removal of cells. It creates clear, distinct boundaries between the digits.
Ah.
And to answer your other question, if this apoptotic sculpting process doesn't occur correctly or completely,
Then what?
you might see conditions like syndactyly, where two or more digits remain fused together because that intervening mesenchyme wasn't cleared away.
Right. Fused fingers or toes.
It highlights the critical balance between cell proliferation and cell death in shaping complex structures.
So as the digits are being sculpted, the internal framework, the skeleton of the limb, is also rapidly taking shape. How does that elaborate bony structure emerge from a mass of mesenchyme?
Simultaneously with digit formation, the limb skeleton begins its intricate development. Starting in week 5, mesenchymal cells condense to form initial bone models.
Like a rough draft.
Sort of, yeah. By late week 5, these condensations start to show chondrification centers, and by week 6, the mesenchyme differentiates further into chondrocytes, forming distinct cartilage models.
Cartilage models.
Essentially, by the end of week 6, your entire limb skeleton exists as a cartilaginous blueprint, a perfect, albeit soft, miniature of the adult bone structure.
A completely cartilaginous limb, that's quite a visual. So when does the actual hard bone start to appear and how does it grow?
Then, in week 7, the process of primary ossification begins. This happens in the diaphysis, or the shaft of the long bones.
The shaft, okay.
This is where cartilage is replaced by bone. By week 12, all the major long bones in the limbs will have established these primary ossification centers.
Week 12.
At birth, the diaphysis is largely ossified, but the epiphyses, the ends of the bones, remain cartilaginous.
Still cartilage at the ends.
Yes. Secondary ossification then kicks off in these epiphyses postnatally, often stimulated by weight bearing. And importantly, the epiphyseal plates, or growth plates.
Ah, the growth plates.
Located at the ends of most long bones, or one end in smaller bones like phalanges, remain as crucial sites for longitudinal bone growth throughout childhood and adolescence.
We've got our cartilaginous skeleton turning into bone, and those digits are perfectly sculpted by apoptosis, a truly fascinating mechanism. But a limb isn't just bones and skin, it needs power and movement.
Absolutely.
How do the muscles, which started as those tiny myotome cells we discussed earlier, find their way into these nascent limbs and organize themselves into the powerful flexor and extensor groups we recognize?
Another excellent question that brings us back to those crucial somites. Remember the myotome part of our somites?
M for muscle.
Right. Each myotome splits into two parts that will eventually contribute to muscles throughout the body. The epimere, a smaller dorsal region, which primarily forms the deep back muscles.
Okay, back muscles.
And the hypomere, a larger ventral region, which forms muscles of the body wall and are crucial limb muscles.
Ah, so the limb muscles come from the hypomere.
Correct. Myogenic cells, those muscle-forming cells from the hypomere, migrate into the early limb buds. Once inside, they don't just scatter randomly, they gather into two main distinct masses.
Two main groups.
Yes, the flexor mass, which will become muscles that typically bend a joint, like your biceps, and the extensor mass, which will become muscles that straighten a joint, like your triceps.
Flexors and extensors. Makes sense.
These larger masses then further split and differentiate into the individual muscles we recognize in the adult limb.
Now here's a great example of an embryonic event that explains a big anatomical puzzle, one that often stumps first-year anatomy students.
Oh.
Have you ever wondered why your biceps are at the front of your arm, considered a flexor, but your quadriceps, the big muscle at the front of your thigh, are considered extensors, like the triceps at the back of your arm? What embryonic event explains this fundamental difference and the seemingly contradictory positioning?
Ah, yes. This is where a truly remarkable event called limb rotation comes into play during week 7. And it's the key to understanding that anatomical puzzle.
Limb rotation, okay.
Initially, both the upper and lower limbs start out with their flexor compartments facing anteriorly, or forward, and their extensor compartments facing posteriorly, backward. And thumbs and big toes point up, cranially.
Okay, so they start the same way.
Exactly. But then they rotate in completely opposite directions.
Oh, opposite, yeah.
The upper limb rotates 90 degrees laterally, so outwards. This means the extensor muscles move to the lateral and posterior side, and your thumb ends up on the lateral side of your hand.
Okay, upper limb rotates laterally, got it.
The lower limb rotates 90 degrees medially, inwards. This causes the extensor muscles to move to the anterior side of the thigh, which explains why your quadriceps are extensors at the front.
Ah.
And your big toe ends up on the medial side of your foot.
Wow, that's such a clear explanation for something that seems so counterintuitive in adult anatomy.
Yeah.
It really makes sense of the biceps-quadriceps dilemma.
It does, doesn't it?
This rotation is also why the originally straight segmental pattern of lower limb innervation gets twisted into a spiral. It's less extreme in the upper limb, but really noticeable down below.
That's right. The nerve pathways follow that rotation.
So speaking of innervation, let's tie this back to our earlier discussion of dermatomes and myotomes. We define them developmentally, but what's their clinical significance? This is super important for you as medical students. Imagine a patient comes in with numbness in a specific part of their leg or weakness in a particular muscle group. How does understanding early embryonic development help you pinpoint where the problem might be?
This raises an absolutely critical question for diagnosis. Clinically, a dermatome is defined as a specific strip of skin supplied by sensory nerves from a single spinal nerve root.
One nerve root, one patch of skin.
Essentially, yes. There are about 30 dermatomes covering cervical, thoracic, lumbar, sacral, and coccygeal regions. Testing sensation in these areas is a cornerstone of a neurological exam to assess conditions like radiculopathy or nerve root damage.
So you can trace the numbness back to a specific spinal level.
Exactly. A patient might report numbness along a specific dermatome. Similarly, a myotome is a muscle or a group of muscles primarily supplied by motor nerves from a single spinal nerve root.
And testing those helps find weakness.
Precisely. Testing the motor function and strength of these myotomes helps clinicians detect muscle weakness or nerve injury, again, pinpointing the level of a lesion in the spinal cord or peripheral nervous system.
So these clinical maps we use.
They directly reflect the orderly nerve distribution established during embryonic limb development and its subsequent rotation. It's truly a map of our developmental history written on our skin and in our muscles.
Unfortunately, not every limb develops perfectly. Limb malformations occur in about 6 out of 10,000 live births, and they are more commonly observed in the upper limb.
That's correct.
While often hereditary, meaning they run in families, they can also be teratogen-induced, caused by environmental factors like drugs or infections during pregnancy.
Let's look at a few common examples that illustrate when that intricate blueprint or the sculpting process goes awry.
Okay.
Syndactyly. As we touched on earlier, this is where 2 or more digits are fused together.
The apoptosis failure.
Exactly. It's one of the most common congenital malformations, occurring in about 1 in 2,000, 3,000 live births, often due to a failure of that apoptotic sculpting process to properly remove the webbing between the digits.
Okay. What else?
Polydactyly. This is the presence of extra fingers or toes. Actually, the most common congenital anomaly of the hands and feet, affecting about 1 in 500 or 1,000 live births.
Extra digits. Why does that happen?
It's often caused by problems in the anterior-posterior patterning during early limb development, perhaps an extra signal for outgrowth where there shouldn't be one. And then there's in polydactyly a wearer condition that combines both syndactyly and polydactyly, fused and extra digits.
Wow.
It's often associated with mutations in genes like HRXD13. This highlights how crucial these specific master regulatory genes and signaling pathways, like the SHAF pathway, are for proper limb development. Even a tiny change in a genetic instruction can have profound effects.
And then we have the more severe limb deficiencies, which are thankfully rarer, but devastating for those affected.
Yes. Things like amelia. This describes the complete absence of one or more limbs, an extremely rare birth defect.
Complete absence.
And meromelia. This is characterized by the partial absence of one or more limbs, where parts of the limb are missing but not the entire structure. Perhaps the most impactful and sobering example of a teratogen causing severe limb defects is the story of thalidomide.
Ah, thalidomide.
Developed in the 1950s to treat a variety of ailments like colds, flu, and especially morning sickness in pregnant women.
For morning sickness.
Oh, no.
It turned out to be a potent teratogen. It caused severe birth defects, most notably phocomelia, where hands and feet appear to arise directly from the shoulder or hip, resembling seal limbs, and also amelia, the complete absence. Over 10,000 infants were affected globally, leading to a worldwide ban in 1962.
That's a truly tragic chapter in medical history, a stark reminder of the immense sensitivity of embryonic development to external factors. But here's where it gets even more fascinating. Thalidomide has an unexpected comeback story, doesn't it?
It does, and it's a powerful lesson in pharmacology and the complexities of drug action. Decades after its ban, thalidomide was repurposed, first as an orphan drug for complications of leprosy in 1998.
Leprosy. It works by inhibiting TNF-alpha, an inflammatory cytokine. Then, in 2006, it became a first-line treatment for multiple myeloma, a type of blood cancer.
From birth defects to cancer treatment.
And it's even being investigated for severe COVID-19 cases due to its immunomodulatory properties. It's a powerful reminder of how complex drug effects can be, how a compound can have vastly different outcomes depending on the dose, the developmental stage, the condition it's treating.
And the absolute importance of rigorous testing, especially regarding pregnancy.
Absolutely. Critical lessons learned there.
And that brings us to the end of our deep dive into limb development. We've covered everything from the foundational germ layers and those segmented somites
And building blocks?
through the ingenious process of limb bud formation, the vital role of the AER as the conductor, the sculpting power of apoptosis,
That crucial cell death.
and the fascinating limb twist of rotation that explains so much adult anatomy. We even explored various limb defects and the cautionary tale and surprising comeback story of thalidomide.
If we connect this to the bigger picture, understanding these embryonic stages is truly foundational for anyone in medicine. It helps us interpret congenital anomalies, understand the segmental innervation patterns we use every day in diagnosis.
Those dermatomes and myotomes.
Exactly. And just appreciate the incredible precision and coordination required for healthy development. The journey of your limbs from a microscopic bud to a fully functional appendage is a testament to nature's intricate engineering.
So the next time you wiggle your fingers, stretch your arm, or take a step, pause for a moment to consider the incredible journey those limbs took.
From tiny bud to complex structure.
From a tiny, undifferentiated bud to the complex functional appendages you rely on every day. What other subtle anatomical features do you think might be explained by an overlooked twist or turn, or even a cellular conversation in our embryonic past?
A good question to ponder.
Keep exploring, keep questioning, and keep making those connections.